Being severely overweight is a major problem in the United States. About 2/3 of the population are at least overweight, obese, or morbidly obese. So there's a continuum of issues. Once you reach the level of severe morbid obesity, that BMI greater than 40, many of the other therapies fail and have failed over time, and that's when surgery comes into play. BMI is a medical calculation of your weight and height.
Anyone with a body mass index or BMI over 40 will qualify for weight loss surgery provided they have insurance coverage. Anyone with a body mass index of 35 and greater can be approved for weight loss surgery provided they have another medical issue such as hypertension, diabetes, obstructive sleep apnea. Weight loss surgery is not just about weight loss, but it is about whole health improvement. It helps with not just losing the weight, but once we can get that weight loss, we see that other medical conditions are helped greatly. We are having patients come off their hypertensive medications. Weight loss surgery is well known and well documented to be very helpful in diabetic patients. Weight loss surgery has also been known to reduce the risk of certain cancers in patients. Prior to having surgery, everyone has the same digestive pattern. Once we put food in our mouth, the food travels down the esophagus into the stomach, and our stomachs will hold about 1 liter of food and fluid as we're eating. That's a big volume of a stomach. And then after it leaves the stomach, it's mixing with digestive acids, it's mixing with digestive enzymes from the pancreas. The liver and the gallbladder are delivering bile to help break down the food we've taken in. And as that food travels through our intestines, the nutrients out of our foods are absorbed into the small intestine just for our nutrition. That's where we get all of our vitamins and our good foods and nutrients as well as the bad ones that we take in. You can't exist without a small intestine and the nutrition that you get from your foods.
Gastric bypass is the longest procedure performed. It was first described in 1968, so we have the most data on gastric bypass.
We want to create a new stomach. Now, we talked about the normal stomach right now being about a liter, a size of a small football, and can hold a lot of food. But we're wanting to decrease the food intake. So the surgeons come down to the very bottom of the esophagus, the very top of our stomach, and they will create a new stomach. So they will staple off that very top of the stomach, which becomes your new stomach. Now, the leftover stomach stays in the body. It doesn't shrivel up and die because it has its own purpose too. But your food will now go into a new stomach we call the pouch, and it's about the size of a grade A large egg. It'll hold just a couple of 3 ounces maybe. So we are drastically reducing the amount of food that anyone can take at one time. You get full really fast because you have a very small amount of space now to fill up. Now, the second portion of that surgery, because the food has to come out of the pouch, it's got to get into the intestine, we're going to go down that small intestine we talked about, and we're going to cut it in half, and we're going to reroute those 2 ends. And we're going to bring one end up to the new pouch, and food is going to enter the intestine from the pouch that way. You're still going to need the digestive acids, the enzymes, and the bile that the body is still producing. And that is going to be delivered through the other end of the small intestine that we're going to bring and attach to the lower intestine. So we are rerouting, and we're giving you a small degree of malabsorption. Now, the malabsorption from the small intestine means that you're not going to get the benefits of some of those nutrients being absorbed into the intestine because we are bypassing a portion of the small intestine. It gives you a little bit of a boost with the weight loss, but the downside of that is that it potentially could give you some deficiencies in vitamins like calcium and iron, vitamin B12. So our patients do need to take vitamin supplements for the rest of their life.
Anybody who's a candidate for bariatric surgery would be a candidate for gastric bypass. There are some people where gastric bypass is a better fit. So if you have severe diabetes or more long-term diabetes, gastric bypass is probably a better fit for you. And if you have reflux disease, bypass could be a better fit for you. Sleeve gastrectomy is the most popular weight loss procedure or bariatric procedure currently in the United States, and it's been that way for about the past 5 years. Basically, we turn your stomach into a tube that's about the size and shape of a banana. So we take off about 75 to 80% of the stomach and remove it. The advantage to a sleeve, it's a little bit less complicated operation as opposed to a gastric bypass.
The sleeve does not touch and it doesn't reroute your small bowel, your small intestines in any way. The capacity of that sleeve is still going to be fairly comparable to a gastric bypass. You'll probably have, about 3 to 4 ounces that you can tolerate. The sleeve does not give patients any degree of malabsorption like a gastric bypass does. So the only thing we're doing in the sleeve is decreasing the volume of the stomach. And I think a lot of people like that as well. You're still going to be eating small amounts of food. So our sleeve patients are still on the vitamin regimen, just as the gastric bypass patients are, because in no way would either surgery allow you to eat the amount of foods you need to take in to get your nutrients and your recommended daily allowances. Vitamins and minerals and supplements are going to be important with either surgery. As with any surgery, there are certain risks or certain complications that any patient may experience. And that a lot of times is no different with bariatric patients. Because they're undergoing anesthesia, they may have some pulmonary or some lung issues. There is a risk for blood clots if people aren't up and moving about and becoming active as soon as possible. But within the bariatric population, since we're operating on the stomach and the GI tract, a lot of times they will experience some nausea and vomiting or even constipation because of the narcotics and the medication they've taken. So those tend to be the more frequent calls we might get, which we have all different kinds of strategies. We have medications to help treat with that. Every patient is sent home with pain medication to adequately control their pain. We do send folks home with nausea medication and medication to help with prevent constipation. All of the post-op, the early and the later post-operative complications are fully discussed with the patient prior to surgery.
Basically, when patients come in to see us in the Bariatric Surgery Center, I'm going to be the first person they're seeing. They will come in, have an initial visit with me. At that point, we'll review all of their medical history as well as medications and discuss any other consults that they'll need before they have their bariatric surgery. Oftentimes, patients have a 3 to 6 month lag time where they have to do supervised nutrition visits. They'll participate in those with myself and our other dietitian. Once that's completed, they will be potentially cleared for surgery as long as any other cardiac or Pulmonary tests have been completed and have been okayed by those consulting teams.
The first step is that patients really need to check with their insurance companies to see if they are covered by weight loss surgery. They are also given the requirements that their insurance has in order to approve them for weight loss surgery. And often those requirements involve, a 3 to a 6 month period of nutritional counseling, either with their primary care physician or a dietitian, and a psychological evaluation. This is a bit of a commitment from the patients. We are asking these patients to totally change their habits, change their lifestyle. We're asking them to change habits that they've had since the days they were taught to eat. And in order to be successful and keep this weight off for years, people need to really make that commitment.
Some of the nutrition goals after bariatric surgery are weight loss for improving health outcomes, and that looks like reducing blood sugar and blood pressure, preventing nutrition deficiencies, and preventing loss of muscle mass. Also ensuring adequate fluid intake. Patients will have to work hard on sipping during the day to ensure that they get adequate fluid intake. Some of the changes in the diet to expect after bariatric surgery, it's a stage approach with an emphasis on nutrition needs at each stage. The first stage is clear liquids, broth, sugar-free Jell-O, those types of things. And then a high-protein nutrition drink is added to this stage, and it's followed for the first week. Then we upgrade to a blenderized or a pureed diet, and we encourage patients to follow this for 2 weeks. After that is a soft, mashable diet, and this is tuna and cottage cheese, something that's, again, easily mashed with a fork. And then finally, after about 4 weeks after bariatric surgery, patients can resume a normal consistency diet, and we encourage lower sugar, lower fat, smaller portions, and high protein then and going forward for the rest of their life. The pouch can only hold about a half of a cup again, and the portion size is really critical to feeling well and helping with weight loss. We encourage protein intakes at meals and snacks to help with feeling full, help with healing, and also to minimize hair loss after bariatric surgery. It's a process to change behavior with regards to choosing healthier foods, making time for exercise, making sure someone is getting enough fluids and taking their vitamin supplements. Some of the resources that we have available here at UVA for support after bariatric surgery is our support group, and this meets once a month, and we talk about nutrition topics. We have a behavioral health specialist that has a special interest in our bariatric population to help kind of navigate their new bodies and their new thought processes. We also have a monthly newsletter that goes out with nutrition information and did you know fun facts, just to keep patients on their journey. We as a team here at UVA support each patient individually and work together as a team to improve patients' quality of life and just feel better physically.
Really, I work to identify any potential mental health issues that could be getting in the way of really positive post-surgery outcomes. So things like anxiety, depression, often folks experience trauma, either in childhood or as adults that have often, they've often used coping strategies such as eating or unhealthy eating really to deal with some of those mental health conditions or some of that trauma. And part of what we do in the Behavioral Medicine Center is to help identify those, work with patients on those pre-surgery, and so that they don't affect things post-surgery. One of the things that we attend to with our patients is follow-up care and provide follow-up care. Often change happens fairly quickly post-surgery, but oftentimes poor eating habits that have been there for quite some time, or some mental health conditions that have been there for quite some time, often come back in the fold sometime later, maybe about a year later. And so one of the things that we really encourage patients to do is to seek help for that. The bariatric team has wonderful support groups that can help assist with that. We in the Behavioral Medicine Center often provide different types of therapy services that can really help address, one, these behavioral changes that they're going to be making and have already made to foster sort of increased behavioral change, as well as addressing better stress management, better coping skills to help them address maybe anxiety or depression or even trauma that they may have experienced.
UVA is the most experienced center in Central Virginia. We've been performing bariatric surgery since the late 1980s. We've trained most of the other bariatric surgeons in the area, and we have a team dedicated to helping you succeed. Number one, the bariatric surgeon.
Every year we also have a laparoscopic fellow. We have a program coordinator. We have 2 care coordinators, registered nurse care coordinators, and then we have 2 dietitians that work with the program. We have access to clinical psychologists that work with our patients, and we have physical and occupational therapists that work with us as well as needed, particularly for patients when they get into the hospital. I love my patients. I really, really do, and it is such a wonderful journey to walk with them as they make this transformation into a new life and a lot of times a whole new person.